Hi guys, today I'll discuss all about anaphylaxis, its definition, sign and symptoms, and its management. Management in different situations like management for infants, management for pregnants, and what are the equipments you should have in your emergency trolley. So by definition, anaphylaxis is any acute onset illness with typical skin features that may be arterial rash or erythema, flushing and or angioedema, plus involvement of respiratory and or cardiovascular and or persistent severe gastrointestinal symptoms, or any acute onset of hypotension or bronchospasm or upper airway obstruction where anaphylaxis is considered possible even if typical skin features are not present. So skin features is always not mandatory for anaphylaxis. Now signs and symptoms of allergic reaction. Mild or moderate reactions. That reactions may not always occur before anaphylaxis. What are those? Swelling of lips, face, eyes, hives or welts, tingling mouth, abdominal pain and vomiting. These two signs, abdominal pain and vomiting, if that is present, you may consider that this anaphylaxis it may be from insect sting or injected drug allergy. So you have to remember these things. Now anaphylaxis indicated by any one of the following signs: difficult or noisy breathing, swelling of tongue, swelling, tightness in throat, difficulty talking and or hoarse voice, wheezing or persistent cough. Unlike the cough in asthma, the onset of coughing during anaphylaxis is usually sudden, persistent dizziness or collapse, pale and floppy, that is for young children. As I said, abdominal pain and vomiting, these are for insect stings or injected drug allergy. What are the immediate actions you should take for an anaphylactic patient? First of all, you have to remove allergen if still present. Second, call for assistance. Third, lay patient flat. Do not allow them to stand or walk. Do not hold infants upright. If breathing is difficult, allow them to sit. So the recommended position is supine or sitting, not standing. You have to remember this thing. Now, first line of management. Always remember, adrenaline or epinephrine is the first line treatment for anaphylaxis. No other drugs, only adrenaline is the first line treatment of anaphylaxis. Not antihistaminics, not corticosteroids, it's adrenaline. Give intramuscular injection adrenaline into outer mid thigh without delay using an auto injector if available, or adrenaline ampule syringe, simple. Fifth, give oxygen if available. Sixth, call ambulance to transport patient if not already in a hospital setting. This is very important. You have to call ambulance for assistance. It may require in further stages. If required at any time, commence CPR, cardiopulmonary resuscitation. You have to commence these if there is any situation where cardiac arrest is setting. Now always give adrenaline first, then asthma reliever. If patient is non-asthma patient and you know that is from allergy to allergy from food or insects or medication, and patient is having sudden breathing difficulty and all the symptoms are like anaphylaxis, then you have to always give adrenaline first even if there is no skin symptoms. Now anaphylaxis triggers and reaction times. The most common triggers for anaphylaxis are foods, insect stings, and drugs. Less common triggers include latex and ticks. Anaphylaxis usually occur within 1 or 2 hours of ingestion in food allergy. The onset of a reaction may occur rapidly also, like within 30 minutes, or may be delayed several hours. For example, in mammalian meat allergy and food dependent exercise induced anaphylaxis, where symptoms usually occur during exercise. So it may be in a set in a few minutes to hours. So anaphylaxis to stings and injected medications, including radiocontrast agents and vaccines, usually occurs within 5 to 30 minutes, but may be delayed. So no thumbs up rule is there. And anaphylaxis to oral medication, that can also occur, but is less common than injected medication. Now adrenaline is the first line treatment, as I told earlier. And how it acts? It acts to reduce airway mucosal edema, that is laryngeal edema, induce bronchodilation, induce vasoconstriction, and increase strength of cardiac contraction. So its action is marvelous action. It acts very fast. That's why it is the first line of treatment. No other drugs can relieve airway mucosal edema like adrenaline. And give adrenaline intramuscular injection 1 is to 1000 into outer mid thigh. The dose is 0.01 milligram per kg up to 0.5 milligram per dose, without delay using adrenaline autoinjector if available, or like a simple ampule or injection. So there is a dose chart is there. You can screenshot this chart and you can remember these things. This is the chart, you can screenshot it. Age, weight, how much adrenaline is required. Okay. As age increase, dose also increase. Now note, if multiple doses are required for a severe reaction, like 2 to 3 doses administered at 5 minutes intervals, consider adrenaline infusion if skills and equipment are available. Okay. For emergency treatment of anaphylaxis, ampules of adrenaline 1 is to 1000 should be used for both IM doses and infusion if required, not diluted one like 1 is to 10,000. The dose is always 1 is to 1000. Now anaphylaxis treatment for infants. Whilst 10 to 20 kg was the previous weight guide for a 0.15 milligram adrenaline autoinjector device, a 0.15 mg device may now also be prescribed for an infant weighing 7.5 to 10 kg by health professionals who have made a considered assessment. So, use of a 0.15 mg device for treatment of infants weighing 7.5 kg or more poses less risk, particularly when used without medical training, than use of an adrenaline ampules and syringe. Infants with anaphylaxis may retain pallor despite 2 to 3 doses of adrenaline, and this can resolve without further doses. More than 2 to 3 doses of adrenaline in infant may cause hypertension and tachycardia, which is often misinterpreted as an ongoing cardiovascular compromise or anaphylaxis. Blood pressure management can provide a guide to the effectiveness of treatment to check if additional doses of adrenaline are required or not. Now, management of anaphylaxis in pregnancy. It is same as non-pregnant women. Okay, 1 is to 1000 adrenaline, 0.01 milligram per kg up to 0.5 milligram. And you should not think about causing reduced placental perfusion or all that. It is a life-saving measures, and you have to give normal dose 1 is to 1000 IM adrenaline, 0.01 milligram per kg up to 0.5 milligram per dose. And the position is very important for pregnant women, as you know, that you have to place the pregnant woman in left lateral position, not supine, not right lateral, it's left lateral, because If you placed in a supine position or right lateral, then the pregnant uterus may cause compression of inferior vena cava, so thus impairing venous return to the heart of pregnant woman. So this is important. Now positioning of patient, as I discussed earlier, always place a anaphylactic patient flat, supine, okay, not in a standing position or walking position. Always it should be standing. That is written in red ink that fatality can occur within minutes if a patient stands, walks, or sits suddenly. Patient must not walk or stand even if they appear to have recovered. A wheelchair, stretcher, a trolley bed should be used to transfer the patient, like to the ambulance, from the ambulance to the treatment room bed, for the treatment room bed to the to and from toilet. So it's supine position or sitting position, not standing. Laying the patient flat will improve venous blood return to the heart. By contrast, placing the patient in an upright position can impair blood returning to the heart, resulting in insufficient blood to the heart to circulate and low blood pressure. The correct way to hold an infant is horizontally, as shown in the image. They must not be held upright over a shoulder. So infant should be, the position should be horizontal, and for pregnant, as I discussed earlier, left lateral position, always left lateral position. Okay, if patient is vomiting, lay patient on their side in the recovery position. Okay, patient with mostly respiratory symptoms may prefer to sit, which may help support breathing and improve ventilation. The patient should sit with their legs outstretched in front of them, not in a chair. Okay, be aware that even sitting may trigger hypotension. Monitor closely. Immediately lay the patient flat again if there is any alteration in conscious state or drop in blood pressure. Do not allow the patient to stand or walk until they are hemodynamically stable, which is usually 1 hour after a single dose or 4 hours after multiple dose of administration of adrenaline. Now, supporting management, when skills and equipment are available, blood pressure, you have to check blood pressure, pulse, ECG, pulse oximetry, conscious state, give high flow oxygen if available, and airway support if needed, obtain IV access in adult and tachycardic and or hypertensive children. The first sign of cardiovascular compromise is in children is ongoing tachycardia. Hypotension can occur later, when it can then be difficult to get IV access, resulting in a significantly prolonged recovery process. If hypotensive, give IV saline. Okay. And additional measures: IV adrenaline infusion in clinical setting. If there is inadequate response after 2 to 3 adrenaline dose or condition is deteriorating, then start IV adrenaline infusion given by staff trained in its use or in liaison with an emergency or critical care unit. IV adrenaline infusions should be used with a dedicated line, infusion pump and anti-reflux valves wherever possible. IV bolus is not recommended because there may be risk of dysarrhythmia. Now, additional measures for upper airway obstruction, you have to give nebulized adrenaline 5 ml, as for example 5 ampoules of 1:1000. Now, consider need for advanced airway management if skill and equipment are available. Now, for persistent hypotension or shock, give normal saline maximum of 50 ml per kg in first 30 minutes. Glucagon in adults, selective vasoconstrictors only after advice from an emergency medicine or critical care specialist. For persistent wheeze, you have to use bronchodilators like salbutamol, 8 to 12 puffs of 100 microgram with spacer or 5 milligram with nebulizer. But bronchodilators, salbutamol must not be used as a first line medication. First line is always adrenaline or epinephrine, because bronchodilators cannot relieve upper air obstruction or hypertension or shock. Now, corticosteroids dose is oral prednisolone 1 milligram per kg, maximum 50 milligram, or intravenous hydrocortisone 5 milligram per kg, maximum of 200 milligram. Steroids must not be used as a first line medication in place of adrenaline. Adrenaline is the always first choice of drug. Now, antihistamines and corticosteroids, there is no such role is there, or they have no role in preventing respiratory and cardiovascular symptoms, and it is contraindicated to use sedating antihistamines that may mimic signs of anaphylaxis. That's why injectable promethazine should not be used in anaphylaxis, because it may worsen hypotension and cause muscle necrosis. Now, corticosteroids is also benefits is not known. Now, observe patients for at least 4 hours after last dose of adrenaline, because relapse may be there, protracted and or biphasic reactions may occur. So, overnight observation if strongly recommended if they had a severe or protracted anaphylaxis, which may require that time repeated doses of adrenaline or IV fluid resuscitation, or have a history of severe protracted anaphylaxis, or have other concomitant illness like severe asthma, history of arrhythmia, systemic mastocytosis, or patient lives alone, or their lives very remote from medical care, or present for medical care later in the evening. So, in these cases you have to observe the patient overnight. That is strongly recommended. True biphasic reactions are estimated to occur following 3 to 20% of anaphylactic reactions. So, this is very important. Post anaphylactic reaction measurements are important. Now, follow-up treatment including advice for hospital discharge. If there is any risk of re-exposure, as for example stings, foods, or cause is unknown, then you have to prescribe, and if possible you have to dispense an adrenaline injector before discharge pending specialist review, and you have to teach the patient how to use adrenaline auto-injector, and you have to refer the patient to allergy specialist. Okay. So, proper referral is also important, because you have to diagnose the cause of anaphylaxis. It may be stings, it may be food, it may be medication. So, you have to refer the patient to a proper specialist. And you have to document the episodes of anaphylaxis. What was the condition? What may be the factors, available cause, and what was the symptoms? You have to record it properly. Now, this is important. What are the equipment required for acute management of anaphylaxis? Your trolley, emergency trolley, should have adrenaline first, 1:1000. Okay. Auto injector is preferable. Then 1 ml syringe, 21 gauge needles, oxygen, airway equipment including rebreather oxygen masks, nebulizer masks and suction, defibrillator, manual blood pressure cuff, IV access equipments including large bore cannula, at least 3 liters of normal saline to deal with hypotension, a hands-free phone in a resuscitation room to allow healthcare provider in remote locations to receive instructions by phone whilst keeping hands free for resuscitation. That means you have to communicate with others. Okay, so these things you have to have your emergency trolley. So that was today's video regarding anaphylaxis definition, sign and symptoms, management in different conditions. Hope you will get benefited. Thank you very much.